Good afternoon, folks. We're going to give this about 10 more seconds before we get started, but thank you for being here. Can everyone hear me okay?
Yes, very. We can.
Excellent. Thank you. Just wanted to make sure volume was working. All right, let's get started. Welcome to Reversing Unintended Consequences of Medicaid Unwinding. My name is Barry Jenkins, and I will be your host and webinar facilitator today. First, we have Jamie Harvey, Agilian CEO, kicking us off in a pre-recorded introduction, with Sorshan, our VP of Value Delivery, diving into the problem space, and Dr. Ross Martin sharing our solutions approach for reversing the consequences. If you have questions, please use the Q&A function at the bottom of the screen, and all your questions will be answered in our Q&A session at the end. Just to set your expectations, I will be monitoring the Q&A session for questions you may have for our live experts to answer. Jamie's introduction will be approximately 5 minutes. Sora and Ross will take about 20 minutes, leaving roughly 10 minutes to answer questions during our webinar. Now, let's start off with a quick poll. This poll allows us to level set to kind of see what challenges you may be facing, and it's great information for us to have. Can everyone still hear me okay?
Yes, Barry, we hear you.
Okay. I got a couple of messages saying they're having hard problems hearing me, but good. And I think we're good with our poll. Now, allow me to introduce you to our CEO, Jamie Harvey. Allow me to introduce you to Mr. Jamie Harvey, CEO of Agilian. Jamie has over 25 years of experience enhancing systems and data integrations with a focus on the Medicaid ecosystem. Notably, he has re-architected a state's health benefit exchange, implemented the modified adjusted gross income eligibility system, both among the most successful in the United States, as well as led digital transformation for managed care organizations and providers. He is dedicated to reducing disparities across communities by enabling managed care organizations, also known as MCOs, to collaborate effectively with regulators and providers to improve member health outcomes. Distinguished guests, I present Mr. Jamie Harvey.
Hi, my name's Jamie Harvey. I'm the CEO of Agilian. Here at Agilian, we are all about the Medicaid ecosystem. We're basically seeking to impact member health outcomes positively. We want to free up time and money for care, and we want to close disparities across communities, across the whole Medicaid community. We got into this because we help do a lot of automation for state regulatory agencies and health benefits exchanges when the ACA came out, and we got really lit up about the Medicaid ecosystem and how much of a difference you can make there. So what do we mean when we talk about the Medicaid health ecosystem? Well, there's people, the Medicaid enrollees if you're a payer, the patients if you're a provider. On the right over there, there's the doctors, the hospitals, the providers, the networks of people that actually provide care to patients. More and more since the Affordable Care Act, there's the payers. There are comprehensive Medicaid MCOs in many states now, as well as smaller regional and specialty plans. And of course, there's the government regulators. And then also in the background, sometimes invisibly, there's also a tremendous amount of data exchange infrastructure living outside of any of these groups, both at private companies, for standards groups, and also some government-hosted infrastructure that's really required to make all of these different pieces work together. So for the sake of the case study today, which was about an MCO client, let's talk about how the ecosystem affects Medicaid MCOs. So, in the center of the graphic, we've put a theoretical Medicaid MCO, and then downstream of the MCO to the right is the provider network. So those blue bubbles represent the kinds of providers that the MCO might get claims from. Hospitals, primary care, specialists, but also long-term care and behavioral health and hospice. And those white bubbles in that cloud represent the provider networks, so ACOs and clinically integrated networks. and groups of community health and FQHCs. So upstream of the payer, the main point of contact, of course, is their state regulatory agency, which actually gives the MCO its charter and funds the enterprise. But that state regulator is in turn regulated by their state executive, legislature, and judiciary, as well as by CMS, the federal government, and the Medicaid and CHIP services group there, who are, of course, controlled by their federal executive, legislature, and judiciary. So, there's an awful lot of cooks in the kitchen. And over the past 10, 15 years, there's been a tremendous amount of innovation and change being funneled from the federal government through the states to the MCOs, as well as innovation being brought by the states by asking for waivers to try new things. So an awful lot of change, an awful lot of innovation, and then several really black swan events that have been really challenging for MCOs and other organizations in the health equity ecosystem to deal with that rate of change. Okay, so to complete this picture, let's lay across the top the humans that the system is there to serve. We don't want to forget about them. And across the bottom, going to layer in some of the data exchange infrastructure, the standards and the hubs and the state Medicaid data warehouses, all very key to exchanging data between these organizations. And then I've also layered in some of the key data and funding relationships between these organizations. So the gray bubbles represent data objects that need to be exchanged between these organizations, and the green bubbles represent the way that money flows, from the federal government to the Medicaid state agency on a PMPM, per member per month basis, to the Medicaid plan, and then getting paid out through claims to the providers, as well as showing that you can go fee for service and avoid the payer. So, because essentially in the 21st century, the social safety net now actually is comprised of data, and the money that flows through is also tied to data, as you'll see from the case that my colleagues will present in the next part. And having worked in every part of this ecosystem, this is really the simplest view I can create, showing an end-to-end view of the relationships between all of the critical interdependent parts of the Medicaid ecosystem. So I imagine when the architects of the ACA were imagining how the law would transform healthcare, they had something like this in their heads, with everything fitting together rationally and creating workability, except there's really one big problem with that. And that problem is that very few of these business data handoffs work as they were imagined to, or as well as they need to create better health outcomes for enrollees, or the kind of health outcomes for enrollees that people imagine that it would. So, there are data snafus at the federal government later. There are data snafus at the Medicaid state level. The provider networks don't interoperate with each other smoothly. There are vendor problems, there are standards problems, and the Medicaid plans end up sort of jammed up in the middle, where they are dependent on good data coming from the regulators, coming to the payers so that they can get their money and claims out to the providers. And frequently, the data that they're getting from upstream from the regulators, for example, those enrollment 834s, don't actually match what the laws say that they should, or what the fair outcome would be. And so we saw this a lot in the Medicaid unwinding, and so that's a really concrete example of the way that this Medicaid technology stranglehold, traps Medicaid enterprises in being unable to meet their missions, and it wastes money, it has bad health effects, and it creates inequity in the populations that they serve. So at Agilian, we spent the last 20 years creating methodology for helping organizations that are in this Medicaid ecosystem free themselves of the problems that are caused by things outside of their control, and to normalize their internal data, to harmonize it across the whole ecosystem so that they can provide these better results. What we do is we help MCOs address these sort of pain points. There are internal pain points like answering business questions, keeping up with regulations, having to do manual workarounds. They have pain points with their providers where the user experience is bad or prior authorization doesn't work. But today we're going to focus on the data problems that they have with their regulators. For example, definitively answering questions about the public health emergency disenrollments, and then also like when what should we do when enrollees are inexplicably churning or when they've been put in the wrong rate categories so that the MCO isn't being properly reimbursed for people that ought to be on an SSI plan but are instead, in a Magi plan, which means that essentially the MCO is left holding that risk. So, we found a very practical set of technologies and techniques and methodology to help MCOs work through these problems. And we're just going to take you through some of the results we've provided for our clients today. So thanks very much. And I'm going to turn you over to my colleagues.
Our next guest is Sora Shin. Sora is our VP of Value Delivery at Agilian. She has over 10 years of experience supporting healthcare and public programs. At Agilian, Sora leads our strategic initiatives and the Value Delivery Office for managed care plans. Prior to joining Agilian, Sora has designed and implemented several programs for Medicaid agencies, such as quality improvement programs for home and community-based services waivers, and COVID-19 contact tracing programs. Thank you for being here today, Sora. But I have to ask, you've been in the Medicaid MCO space for most of your career. What keeps you here?
Thanks, Barry. As mentioned today, the Medicaid ecosystem is very complex with many players, stakeholders, and ever-changing rules and regulations. We may not be reminded by our day-to-day, but what I want to emphasize is that all the complexities of this ecosystem exist for one purpose, and that is to serve Medicaid beneficiaries. The reason I'm here and why we exist as an organization is to make these complexities a little simpler for all involved so that together as a whole, we can become better at serving that one purpose of supporting Medicaid enrollees, impacting their outcomes, and closing disparities across communities. Today, we'll be taking a look at one strain of complexity that has been posed in the ecosystem and how that affects Medicaid members. During the COVID-19 public health emergency, the requirement for states to renew eligibility each year was suspended. With the public health emergency officially ending in May 2023, the annual renewal requirement was reinstated, and states resumed normal operations to verify current beneficiaries' eligibility to continue receiving Medicaid benefits, and if they were found ineligible, states terminated their Medicaid coverage. This process of returning to regular renewals is referred to as the Medicaid Unwinding. During this process, more than 22 million people who are on Medicaid were disenrolled. Of those 22 million, 15 were disenrolled for some administrative reason, which is referred to as procedural disenrollments. While not all 15 million people were necessarily eligible for Medicaid, a significant portion of them were, and they were disenrolled because they failed to respond to information requests from state Medicaid agencies. To highlight a major concern here is how this affects children. Children have higher eligibility levels than adults, and it's likely that many children who have been disenrolled for procedural reasons are still income eligible for Medicaid and CHIP, but they lost their health benefits because of administrative barriers. A question for MCOs, and one that we have been helping our clients with, is how many of your eligible members were wrongfully disenrolled during the unwinding? MCOs play a critical role in this ecosystem, managing coverage and coordinating services while managing costs for state Medicaid agencies. During COVID, there was a surge in Medicaid enrollment that placed strains on MCOs in managing larger populations, and now with the unwinding, MCOs are met with a different set of challenges. What are some of those challenges affecting MCOs? First, financial loss. The unwinding directly impacts revenue, often leading to financial loss for MCOs. Most troubling is the financial loss from wrongful disenrollments because those members shouldn't have lost coverage, and MCOs shouldn't have lost those members. Second, overhead burden. Addressing disenrollments demands administrative efforts, including managing appeals and grievances while working with state agencies to fix enrollment issues. These additional burdens take away time and resources from other important functions. Disruption to continuity in care. When members lose health coverage, especially when they shouldn't have, it disrupts their care, makes it harder to access the care they need, which worsens outcomes and cycles into higher healthcare costs. There are also compliance risks. If states fail to follow CMS requirements and guidelines around the unwinding, MCOs may unintentionally also be violating regulations, and this can put MCOs at risk of contract noncompliance. MCOs may also be impacted by consequences that CMS puts on states for failing to meet unwinding requirements such as corrective action plans, civil monetary penalties, and reductions in the state's federal match. Membership growth and retention challenges. The Medicaid unwinding problems can affect MCOs' capacity and attention to support their members and providers. This can hurt their reputation and ability to attract and retain members and providers that impact future growth for the MCO. Operational challenges. Disenrollments create operational workarounds, complicating processes like eligibility, claims processing, communications, and network management. These challenges strain existing operations and require MCOs to adapt their workflows to address disenrollment-related issues. These challenges affect MCOs on multiple levels, from the organizational level of leadership, culture, and responsibilities, through to the behavioral, procedural, and technical controls in place, as well as the day-to-day operational processes that we just mentioned. Let's take a closer look at procedural disenrollment and its impact on members. 69% of Medicaid disenrollments during the unwinding were due to procedural reasons. So what are procedural disenrollments and why do they occur? Individuals are disenrolled for procedural reasons when the state needs additional information from them to determine if they remain eligible for Medicaid, but don't receive this information. There are a variety of reasons why this happens. Sometimes it's as simple as the mail not reaching them because the Medicaid enrollee doesn't live at that address anymore, or the renewal notice is confusing or not in their preferred language, and it's also not uncommon for paperwork to get lost after it's mailed. If enrollees can't get through to the call center, they might run out of time before the state terminates their coverage. Not all of the 69% of the 22 million lost their Medicaid coverage because of these reasons. Maybe someone didn't respond to the information request because they knew they no longer met the income requirement for Medicaid because they got a new job, but a good portion of them did. Now, imagine how disadvantage is compounded for someone who has low or no income and is on Medicaid, may not have a permanent home for mail to be delivered to, may not have the best access to internet or a computer, may not live near a post office to mail back the documents, may not have a car. They missed the deadline to submit the forms, and the next time they go see a doctor, they're hit with a bill that they can't pay because they found out their Medicaid coverage was terminated. Now, there are federal guidelines, authorities, and flexibilities that states can adopt to support the unwinding process and maximize enrollee retention, but it's on states to adopt and implement these authorities. Any way we can help MCOs and states make this process and transition better for Medicaid beneficiaries is why we are here. Here are several factors that we've seen worsen the effects of wrongful disenrollments for MCOs. Data silos. Data systems that don't talk to each other and thereby the lack of data transparency within MCOs cause key information to be missed, delay resolving disenrollment issues for weeks and months, and impair decision-making, all impacting access to care for members and revenue and scalability for MCOs and providers. Administrative burden. There's not enough people or time to manually verify, validate, and resolve the eligibility discrepancies, leading to wrongful disenrollments and delays in getting them fixed. Poor communication. Getting the right information to the right people by the right time is challenging, especially when communication has to happen between so many players: CMS, Medicaid agencies, MCOs, providers, and enrollees. Poor communication worsens disenrollment challenges and results in confusion and frustration, especially for Medicaid enrollees, not to mention the negative impact it can have on their health. Disenrollment, especially when they shouldn't have been disenrolled, disrupts the care enrollees need and leads to avoidable healthcare costs. I've spent some time today on why we're here, and many of you are probably wondering how these challenges can be addressed. So I will turn it back over to Barry for us to continue that conversation.
Our final panelist is Dr. Ross Martin. Dr. Martin is our Chief Medical Informatics Officer and Chief Innovation Officer at Agilian. Previously, he was a Program Director at the Regional Health Information Exchange, VP of Policy and Development at the American Medical Informatics Association, Specialist Leader at Deloitte Consulting, Director of Health Information Convergence at Bearing Point, and Director of Healthcare Informatics at Pfizer. He has worked as an obstetric house physician and as a professional writer. Now, Dr. Martin, you've been on all sides of this ecosystem. What is your one takeaway from your years of experience?
Thanks, Barry. That is, in fact, the deep question, but I'll try to give an answer that doesn't take up all my time. You know, one of the reasons I chose to stop practicing medicine and transition to medical informatics is that I saw just how broken our system is, and I knew I couldn't fix it taking care of one patient at a time. Now, at the beginning of the webinar, Jamie did a great job highlighting the complexities inherent in just the Medicaid ecosystem. I wanted to work on those larger systems level issues that were preventing us from achieving better outcomes. But how? Eventually, I found that we had a fundamental problem with data flow, as well as a misalignment of the incentives driving the way healthcare works in the US. We've made a good deal of progress on both fronts over the last 30 years, especially with the data flow issues, as we increasingly move away from paper and fax machines to manage health information and the financial transactions around them in a better way. But with every innovation comes new unintended consequences, like the ones we're talking about today. So I guess to sum up my one thing answer, it would be to say that as we make progress on addressing systems level issues, we need to continue to solve for the general issues of data quality and data flow. And that the better we get at data quality and flow, the easier it will be to rapidly address both new challenges and the unintended consequences of those new solutions. So what I'm going to do in the next few minutes is talk about the work of Agilian for some of our Medicaid MCO clients and how by improving their fundamental capabilities through data integration and flow, we were able to help them quickly address one of the unintended consequences of the Medicaid unwinding. That is, the large number of procedural disenrollments that have adversely impacted members who shouldn't have been subject to a disenrollment, like Sora was explaining a while back. But before I dive in, I just want to step back from all the big picture data and workflow stuff and bring it down to a human level. I think about my time in residency when I spent a couple of months at the neonatal intensive care unit back in the hospital where I trained. There were dozens of premature babies with lots of complex medical interventions, keeping them alive, costing thousands of dollars a day. Then there were the parents and caregivers who often felt like they were entering into some surreal nightmare as their newborn was struggling to survive. Now, imagine being one of those parents receiving the news that they were no longer covered by insurance. This is one of the reasons we are so passionate about our work here at Agilian. Our work is deep in the weeds of data flow and business processes, but we know that we can have a positive impact on many, many human lives. Impacts that, by removing a disadvantage like the loss of coverage for someone already burdened by adverse social determinants of health, we can have an exponential positive impact on that individual and the many others similarly affected. So now let's take a look at one real-world example that had a real impact on real lives through our work with our Medicaid MCO clients. Sora spoke earlier about one of the unintended consequences of the Medicaid unwinding process, the procedural disenrollment of individuals who were still eligible for Medicaid, but for one reason or another did not complete the appropriate steps to maintain their eligibility status. Now, we saw this issue in multiple MCOs, but I'll present it as a single client with all the identifying details removed. This client had a plan that included members who were qualified for Supplemental Security Income, or SSI. The client experienced a sudden spike of disenrollments during the Medicaid unwinding process. It was unclear whether there was a problem with the state regulator or the Social Security Administration. What was clear, however, was the sudden and devastating impact for enrollees and for their families, as well as a sudden loss of revenue for the MCO to the tune of more than $20 million annually. Now, see that graphic above my head? That's an innovation architecture, business ecosystem architecture summary. That's a whole lot of buzzy words, I know. I'll get into explaining that more in a minute. But for now, look on the right-hand side under Funders and Regulators, where you'll see the under State, Medicaid Enrollment and Enrollee Management. That represents the business process of, among other processes, exchanging 834 eligibility files with the state. You can imagine the alarm bells that went off for our client when they received 834 eligibility files from the state that were missing a large number of enrollees. I would like to describe how we helped our client address this issue by explaining our core process for supporting our clients, something we like to call the Agilian way. Now, whenever we engage with a new client, that engagement is usually triggered by some crisis or important change, like a merger or acquisition, that they need some help addressing. But rather than diving into the weeds of that specific problem, we first start with a bigger picture examination of the enterprise, something we call innovation architecture. We find that when addressing specific problems, we will probably provide an incomplete solution if we only focus on that problem. Fortunately, we have a lot of experience in the domain, so we come in with a well-developed sense of their enterprise and quickly work to refine it and specify it for that particular client. Now, let's talk a little bit more about innovation architecture. Innovation architecture is a streamlined version of the larger discipline of enterprise architecture that looks at 4 layers of an enterprise. One, the business architecture, which is all the business processes that make up the operations of an enterprise. The application architecture, all the software applications that support the business processes. Then the information or data architecture, that's all the data that flow into, through, and out of the enterprise to support the business. And finally, the physical infrastructure architecture. That's the physical part of the architecture that shows where all the applications and data live, the servers and things like that, the cloud. The image on the right-hand side of the slide shows a summary version of a much more complex business architecture, that first layer, for a typical Medicaid MCO, all de-identified, of course. Now, because we did all of this innovation architecture work on the front end, when an unanticipated problem came up, even though the client had not anticipated this problem, we already had the framework for a solution in place and were able to help them quickly address the issue. I'll describe our solution on the next slide. What we've learned in our many years of addressing particularly challenging ecosystems and problem sets is that it is not very helpful to overfit a solution to any given problem. That's generally what leads to unintended consequences. But by going through the discipline of our innovation architecture process, we can begin the work of building a modular ecosystem of MCO accelerators for our clients. I like to think of it as an integration stack or a universal serial bus that connects people to applications and data and make it useful in any number of scenarios, like a Swiss Army knife for MCOs. We'll save a deeper dive into these accelerators for another webinar, but I will point out 3 critical components that came into play in this particular solution. We worked with the client prior to this particular disenrollment issue to take data from siloed databases and systems and federate it in the cloud. Now, we like working with Amazon Web Services, AWS, but can provide similar services in other cloud environments. Having all this disparate data in one serviceable place makes it possible to then create automated data management processes so that maintaining the data is not an overwhelming burden. We can then work with the client to develop business process specific dashboards. So when this disenrollment issue came up, we didn't have to start from scratch. We were able to quickly help them create views of their enrollment data using assets in the integration stack and drawing data from the cloud-based data warehouse to identify enrollment and disenrollment insights and trends. This literally happened over a weekend when we were notified on a Friday and had insights by Monday. We were able to harmonize the meaning, terminology, and taxonomy of their data and the data coming from the state to see how these high needs individuals were unintentionally disenrolled during the unwinding process. Now, that's not the end of the story, of course. We also helped them present their case to the state in a way that wasn't about placing blame, but about returning people to an insured state by producing documentation of unequivocal proof of eligibility. The state regulator was quickly convinced, and as a result, more than 1,000 enrollees had their Medicaid coverage reinstated, resulting in a recovery of about $26 million annually if you extrapolate the impact. These were high needs individuals who never should have been disenrolled, but without the data to back the claim, it would have been a significant challenge to reverse these disenrollments. What I just described to you was made possible because of our digital liberation framework, another name for the Agilian way, that is summarized in this slide. It speaks to the way we structure our engagements with our clients and frames everything we do for them. Because it's not enough to deliver a technical solution. It has to align with your vision as an organization and be spurred on and enabled by an organizational learning process that keeps you moving forward. So this matrix of design, deliver, and improve, orchestrate, integrate, and learn, everything we do fits into one of those buckets and makes this whole system, whole process, whole philosophy of doing this kind of work. That's pretty much the end of what I wanted to share with you. Thanks for listening. I now think I will hand it back to Barry, who will take us into a Q&A session to wrap up this webinar.
Thank you very much, Jamie, Sora, and Ross, for your time today and your insight. And now let's get into some question and answers. If you do have questions, you can actually use, again, the Q&A tab at the bottom, type in your questions, and we will read them and have our panelists answer them.
And I'm going to ask Carolyn to stop sharing her screen. I think we can, so we can see everybody.
Hang on. There we go.
So, first question. How do you ensure that Agilian's approach is adaptable to different state Medicaid programs with varying regulations and requirements? I believe this question is directed toward Ross. You're on mute.
I apologize for that. Wow. It's true what they say about, when you've seen one state Medicaid plan, you've seen one state Medicaid plan. So when we enter a new market, we assume that we will find a different approach to regulating Medicaid MCOs and different operational methods for implementing those regulations. That's just a given. And part of our discovery process includes developing a detailed understanding of the of that process by doing what we call a CMS and state enrollment traceability matrix. This maps the relevant CMS regulations for each state's plan, but it also maps the available data on disenrollment categories. So in other words, we don't start from scratch because we find that while Medicaid implementations vary from state to state, we have found that common themes and variations exist. So we come in starting with some assumptions, but we verify those assumptions before recommending a strategy. I hope that addresses your question, but you can follow up with one if you need to.
Thank you, Ross. Appreciate that. Our next question. What Medicaid populations have you helped with disenrollment recovery, with disenrollment recoveries? I'm going to direct that one over to Sora.
Thank you, Barry. Yes, we've worked mostly with supplemental security income, SSI eligible individuals, such as individuals with social health care needs and managed long-term services and supports populations.
Excellent. Oh, and I think there's a follow-up question to that. How big were the plans you worked with?
Without naming our clients for confidentiality reasons, we've worked with specialty plans with less than 10,000 members to Fortune 100 MCOs with over hundreds of thousands of members.
Excellent. Thank you so much. Now, if there are not any more questions, we're going to do one last poll. I'm going to give it about 5 more seconds to make sure no other questions come in.
Barry, I just want to make one more, final comment about just to emphasize what I shared a little bit earlier, saying that, by building an integration stack and by building the kind of solution matrix that we have in place, the important thing is that was not predetermined. We did not know that this disenrollment, problem was going to come up, but we had sort of a universal widget, being able to address any question that came along, not any question, but a broader set of questions. Again, it just emphasizes the importance of not overfitting your solutions to a particular problem. And I think we have another question.
We do. How do you see differences in MCOs versus state Medicaid operations? Sora or Dr. Ross, either one could answer.
Well, Sora has more experience in the state Medicaid operations, perhaps. So I don't know. Do you want to take a stab, Sora?
Well, I think the main difference from the state level that I've seen is when the state is administering the Medicaid program, they have different divisions in charge of different functions of running that plan. But when they work through managed care organizations, it really becomes more risk-based, right? Because it's up to the MCO to work within this PMPM per member per month to make sure they're delivering the best care they can within that set amount. So it becomes more coordinated, hence the name managed care. And I feel like from my perspective, I've seen more effective ways of innovation when managed cares are running the health plans for states. Ross, any thoughts?
Yeah, I guess one of the fundamental differences is that the MCOs often are multi-state entities. There are certainly ones that are exclusive to a particular region, but many of them have to deal with 5, 6, especially the larger enterprises, and so they need to find ways to interpret all of the federal regulations as ecumenically as possible, so that when they deal with a specific state and their the state Medicaid plan of how they're going to implement, that they can find a common solution or common platforms to solve and address those same issues. And I think they also have the opportunity. It's not that the states don't talk to each other and do a lot of learnings. There are lots of associations of the state Medicaid directors and the other staff, so they do share information and share learnings. But the MCOs often can port those things from place to place.
Oh, and one thing while you're talking, Ross, that came to mind is also with MCOs, there are often more than one within a state. And so there's some level of choice for enrollees and beneficiaries and who they work with for their coverage.
Yeah.
Great question. Thank you very much. Any more popping in at the last second here? All right, we'll move on to our last poll. And again, this poll is actually going to help us make sure that we are delivering the best possible information to you and your organization. And while you're answering that poll, we just want to say thank you very much for the time, your time, and spending time with us today. And you will be receiving an email, follow-up email to this webinar. And we look forward to seeing you in our next webinar scheduled for this fall. Thank you again for your time again, and we'll see you next time. Take care. Thank you from Agilian.